a while back, a 23-year-old kid whose family came to see me with an MRI. This child had a very high grade glioblastoma, which is a brain cancer, deep in the brain. Okay. Now they had gone to see 3 surgeons at big hospitals who said that we can surgically excise this, but it's in a very dangerous location, so we'll remove 70% of the tumor and we'll do a biopsy, and then based on that we'll decide what to do.
So they'll remove 70% but not entirely?
Because the location is just too problematic. Okay. So even removing...
But just now you explained to me even 4 cells can,
Correct.
make it make it worse again.
Exactly.
So leaving 30%
is problematic, right?
Yeah.
Now, but sometimes reducing tumor burden may give you quite a bit of time. Okay, see, if you go to 4 cells, for it to get to where you were may take 2.5 years.
Okay.
So at least you're getting that 2.5 years.
Yeah.
Okay. Now, they came to ask me, who should we pick out of these 3 people? So I again sat down, explained to them what is the nature of cancer, what the different treatments are, and then I told them that there is something called the standard of care, which based on historical data tells you what is likely to happen. So in a high grade glioblastoma, if the tumor were in a very accessible part where you can remove everything that you can see, okay, the increase in overall survival is 5.5 months. So if you remove only 70%, what are you going to get?
Okay, so even if you removed 100%,
all of it, it's 5.5 months of increase in overall survival. So I said that in what universe is this good for you? You're spending 10 lakhs for a surgery. You are
not even getting 5 months.
You're not even getting 5 months, and the surgery by the surgeon's admission carries a 25% risk of mortality and severe morbidity.
Okay.
So all you're getting is the mortality and morbidity, and you're being parted of 10 lakhs of rupees.
Yeah.
Now why am I telling you this? That see, the surgeons were holding out hope. They said that we'll do this. Now you are a lay person, you feel that okay 70% तो निकल गया.
Right.
अभी फिर biopsy करेंगे, फिर वो आगे मुझे रास्ता दिखाएगा. Okay. Now what I am telling them is actually terrible. What I am telling them is, your kid is going to die. There's nothing you can do about it. So they were shocked, they were very heartbroken, and they essentially said, we'll think about it and get back to you, and they were in tears. Now what I also told them is, let's see, this is not just something that I am saying. I will have my people share the data with you because this is in the public domain. So after a fortnight, they came back to me and they said that we've thought about it, we've spoken about it, and we know that you're right. Tell us what to do next. Now ultimately, it was fortunate for the child that we were able to give him a reasonably good quality of life for about 1.5 years, and his end was peaceful. And in the process of this journey, I saved them about 25 to 30 lakhs. Okay. But now I was able to do it because they trusted me at every step of it. This first conversation was a very hard one.
Right.
Because I was the bearer of bad news.
Yes.
And I had to have that conversation in a manner where they would still ultimately believe in me. Because the best advice in the world is of no use to anyone unless they listen to it.
True, very true, very true.
So part of this whole exercise is how do you honestly win the trust of people. So the gold standard of knowing what you what it is to do a biopsy. But the surgery is fraught with risk. So what are the ways of doing the biopsy? One is to do it endoscopically, but you can't do it in this patient because the patient is shunted. So now what you need is a stereotactic biopsy. Where will you do the stereotactic biopsy? Okay, so if you have a very good person, the risk of adverse events in the stereotactic biopsy is only 1%.
Yeah.
But it could be as high as 5%. So how do you get the best price performance for the 1%? Because if this thing turns out to be a germline tumor, or on the off chance, low chance, it's a lymphoma, then you can cure this patient. So you can't let that 10% go. Okay. So now you have to help them with all this stuff, right? Now, unfortunately, the 90% that you were expecting is what it turned out to be. So now what's the next step? Now all this stuff is included in that 3 lakhs.
Yeah.
Okay, your strategy is coming for 3 lakhs, but see, just the fact that I averted that useless surgery, that's straight 10 lakhs in the bank.
Yeah.
Okay. Plus you didn't undergo a unnecessary neurosurgery. I mean, even if you were in the lucky 75%, it's not without, I mean, it's not a walk in the park.
So the reason I asked is, India may, not just in medical fraternity, people are unwilling to pay for advice for anything. So
Correct.
I talk a lot about finance, and there's a big issue that you should. It's a SEBI regulation. It's not an issue. Sorry, it's a SEBI regulation that you should get financial advice from SEBI registered financial advisors. Now everyone in India needs to learn how to manage money, and no one actually does. No one knows how to manage their money. And if you're investing 25,000 rupees, yeah, maybe 5,000 rupees every month, it doesn't seem logical as logical for an Indian mindset to pay for advice, to pay someone to understand how to manage your money, how much to allocate, where, asset allocation, everything. So people have this notion, they want to see concrete things. It is very sad, but someone would pay for a fancy surgery that does nothing because they can see it, it's something in front of their eyes, and they would be happy if it fails. They would feel more satisfied that we did our best, we
Correct.
spent our money, and then we failed. But they would not be as comfortable paying someone 3 lakh rupees in advice just to hear that they cannot do something. Now for them it feels like मैंने इस बात के 3 लाख रुपए थोड़ी पे किए, कुछ करके दो मुझे. What they don't understand, you can correct me if I am wrong, what they don't understand is the person who is taking 3 lakhs for them is not taking for a 5 minute का consultation or a 1 घंटे का consultation for that matter. He is then responsible to lead your entire strategy, entire operation.
Correct.
And then come to a conclusion कि ये नहीं हो सकता है. Now how?
और हो सकता है.
Yeah, और हो सकता है.
See, the thing is, if that stereotactic biopsy had given a germline,
Yeah.
you would have cured the patient, okay, without any of the associated risks of the surgery.
Yeah.
So what will happen, nobody can anticipate.
Yeah.
So that you're absolutely right.
So
so the way, but there's a different take that I have, right?
So I'll just complete myself because that's a question leading your way. People are not comfortable paying huge amounts of money for consultation only to listen to bad news, right? People then think ये तो कुछ भी नहीं हुआ. This reminds me of a movie. This reminds me of 2 instances, both from movies. One was I think Jolly LLB, when Baman Irani, who was defending a criminal, the villain said कुछ तो कम करो लीगल फीस में क्योंकि ये तो बहुत जल्दी काम हो गया. देन ही रिमाइंडेड देम कि जल्दी काम करने का ही मेरा पैसा है, तुम्हें लंबे टाइम जेल रखने का पैसा नहीं लिया मैंने, राइट? 6 महीने में आप बाहर आ गए, दैट्स व्हाट माय एक्सपर्टीज इज, एंड पैसा इज फॉर दैट एक्सपर्टीज, राइट? Whereas an Indian mindset is, there's another movie, I think it was from Tanu Weds Manu, there was this shauchalya where you pay and go use the restroom. So this protagonist was coming out of the restroom, and the man standing at the door said, "Give me 10 rupees." He said, "I won't give you 10 rupees because कुछ हुआ ही नहीं मेरा. I didn't poop." So, and that automatically makes sense for the audience that he should pay because he did block that room. He did go inside. It's his problem whether he pooped or not, but he did use the service. why do you think people have a hard time understanding that the consultation fees is more transparent? You can hold the doctor responsible, and the doctor can do a better job because he is making his money the honest way. He won't be incentivized to scam you in any other way. And
right.
yeah.
So the way I put it is that it's almost like telling your lawyer that I won't pay you.
No.
You get the money from wherever you want.
Yeah.
Which the most obvious thing is the opposite side.
Yeah.
Okay. So essentially that's the representation you'll get.
Yes.
Because at the end of the day, unless that person is some rich fellow of independent means who is, really sort of out to get sainthood, how is he going to deliver the goods?
Yes.
Okay. If I need that neuroradiology opinion, if I need that surgical opinion, because I am neither, okay, how is $2,500 going to allow me to do that?
Yeah.
I have to tell you whatever the hell I think, right?
Yeah.
And that cannot be good enough because that person is a neuroradiologist for a reason,
Yeah.
right?
Yeah.
So even if you pay the bare bones cost of what these people will charge, forget about the frictional cost of making the engagement happen, etc. It just won't add up.
Yeah.
But my take on this thing, what I tell my people in C3 is that ultimately this is a challenge for us because, see, the law firm can charge, $250,000 for a consult and $50,000 an hour, or there are lawyers who can charge lakhs of rupees for an hour and people happily pay it.
Yes.
It's our fault that we are not being able to make them pay.
Yeah.
Okay.
Yeah.
I mean, ultimately that has to be your goal. See, the easier part is not to do that and basically get money of other things.
Yeah.
Okay.
Yeah.
It's the expedient way of doing it. See, essentially, if I refer somebody for a 10 lakh surgery, I can get 2 lakhs as a referral, which you can call it a marketing cost for that person, right? That's all fine. But the point is that now my interest is not aligned with the patient.
Yeah.
My interest is aligned with something else altogether.
Yeah, you will just spend 5 minutes with the patient only to send them away to a doctor or another hospital because you get your incentive from that place.
Exactly.
Yeah.
So it's a complete misalignment. Now, when you pay your lawyer, 20 lakhs of rupees, you are incentivizing him to fight the hell for you.
Yeah.
Okay.
Yeah.
If you say to 20,000 mein kar le, okay, but his overheads are only 1,50,000.
Yeah.
He has to get that money from somewhere else.
Yes. Yes.
Okay. Now, when you are vulnerable and when you have no knowledge, it's very easy for me to get that money from somewhere else.
Yes.
Okay. But now, the incentive structures are entirely against you as a patient.
Yes.
So, in a way, that's another responsibility that we have to take, that we have to become aspirational enough by building that credibility, that brand, right? I mean, see, like, people will pay $20,000 for a consult at Harvard Medical School.
Yes.
Okay. That's the price of it. And there are people who are willing to pay it because they've built that institutional reputation. So ultimately the long-term goal is, and the vision is, that you must be perceived that way. Okay. There must be institutional reputation, and see, once you build that, people pay for things. Say people pay for the most worthless things.
Yes.
Okay. I mean, there are people who will pay $1.5 lakh a month to dietitians for cancer. No.
Yeah.
It's not entirely clear what the hell they can do. Such a thing doesn't exist in the real world.
Yeah.
Right? But I mean, people who are good at doing this thing, they are able to command that 1.5 lakhs a month. So maybe that's the part we have to learn from them. See, the other thing is, knowing and explaining are very different skills. I am a good explainer because I did it 25,000 times. I was not born with it. Okay. So if the system does not have explanatory frameworks in it, then very smart people will know what to do
Right.
But to explain to them is a completely different skill.
Right.
That skill has to be nurtured. Then you have the product.
Yeah. I went to multiple doctors in my city for one particular basic thing. So the behavior that I got in return was poor. I know I'll be thrashed for this, but it is what it is. So one of the doctors told me, तुम डॉक्टर हो क्या? तुम्हें क्यों जानना है ये सब? तुम्हें क्यों पूछना है ये सब? Are you a doctor? No, I'm not a doctor, but I'm a consumer. I'm paying for your services. I deserve an explanation. If you don't give me an explanation, I will be motivated and forced to ask stupid questions that might irritate you, because of course you have 30-40 years of experience and I'm a noob to you. And you have a right to get irritated because a lot of people go after doing some stupid Google research, and doctors often get irritated. There are hospitals who have put this notice board in their premises. Please Google search करके questions ना पूछें, we won't answer you, blah 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 blah. But I think even that is a bit extreme.
Yeah.
A noob person who is suffering from something and paying for the treatment has all the right to know what is going on, and please increase your advice, please increase your consult fees. I'll pay that, because I was never given an option कि ये सस्ती वाली कंसल्ट फीस में तुम जा रहे हो, इतने में इतना ही मिलेगा. I was never told that. I went to see the top doctor at a top hospital. He scolded me. Are you a doctor? तुम्हें क्यों समझ में आएगा ये? तुम्हें मतलब they make you feel very small. And this is my frustration coming out.
Yeah, so that's what. I don't feel that, especially when it's your concern.
Yeah.
What I've found is that the rickshaw wala can understand the same conceptual framework when it concerns his wife as the McKinsey partner.
Right.
And I'm telling you this from experience.
Yeah.
It's not about the sophistication at which you understand it. It's about what are the issues.
Yeah.
Ultimately, you're grappling with very human problems. Okay. I mean, if I tell you that, the overall survival for a high-grade glioblastoma is 5.5 months, you can ask many very nuanced questions, which you say neurosurgeons and medical oncologists and neuroradiologists will have a very different conversation. But what is germane is the fact that this is the reality. Why it is so, and all that is not germane to neither the McKinsey partner nor the Dhobi.
Yeah.
Okay. You have to cull out what matters and convey it in a manner which is appropriate.
Yeah.
Now the other important thing is that, see, every cancer patient needs to understand what cancer is. Do you need me to do that? Not really. Okay.
Yeah.
You train people. So see, what happens abroad is that a lot of the explanatory stuff is not done by your primary physician. Okay, because I'm a very high value resource.
Yeah.
Okay. I don't need to spend that hour. It has to be a person who is knowledgeable, who is compassionate, who is caring, who will engage with the person, who will win the trust of the person, right? And that reduces my burden by 80%. I'm not saying that I'm not going to engage.
Yeah.
But now my 6,000 patients can become 35,000, no?
Right. Your time is much more valuable that way.
Exactly. Okay. So you see, you don't actually have to build in the cost of the 7 lakh rupee doctor for the 1 hour engagement entirely.
Yeah.
Okay. See, every once in a while, you have things which are very complicated. So now, see, I had a patient about 7 years back who was young patient, 30 years old, just married, 20 weeks pregnant, locally advanced breast cancer, first child, okay, and she had a BRCA mutation.
What is that?
So it's a genetic predisposition for ovarian and breast cancer. So now, all in all, this is a very bad story. So they went to multiple people, all of whom said that if we do your chemotherapy, which is what we need to do up front, you're destroying the fetus. If you wait till term without doing this, your kid will be fine, but there's no way of saving you.
Okay.
No, this is a very difficult problem for somebody who's 30 years old, just married, and they are in this, and they have this kid,
Yeah.
and they are told that you can't really have another kid, right, because of this BRCA mutation, etc.
So if they go ahead and save the mother, she won't be able to have another kid in future.
No, she won't survive at all. She'll die.
No. If
Yes, if they save the mother, they can't have another kid.
Yeah.
Yes,
Okay.
correct. So now they came to me and I said that there is a potential path. So I reached out to my colleagues abroad in a place where there's a division of oncological cancer in pregnant women. So I was able to reach out to the best centers in the world which did this thing. They said that we will guide you through this. We found a path, we treated the person, and 6 months back this lady came with her 6.5-year-old child. The mother is
Wonderful.
fine, the kid is fine. Now, why am I telling you this story? Let's say I couldn't have done this without the input from a fantastic center. Because though some of these places may be expensive, they're very super specialized. So here, I mean, if a person comes to me with breast cancer, lung cancer, liver cancer, I will help everybody with everything. Okay. At a Mass General, okay, in first the breast cancer people will only go to the division of breast cancer. That is broken up into multiple subdivisions based on receptor status.
Okay.
So these guys really are extremely good at what they do. Now, by and large, you don't need it, but in the 5-7% instances where you do, we have the reach to be able to do this. And we do not, up till now, we have not charged any penny for it.
Oh. So basically what you're trying to build is a center that is within your reach, not very costly, where the doctors are held accountable, will not lie to you, will not prescribe you unnecessary expensive treatments, and if need be, will reach out to top institutions from anywhere in the world to help you with your case.
Kind of, yes. So now let me give you an example. I had a patient who came to me from Nepal.
Nepal.
Very rich patient. She had breast cancer and she was reported as being ER/PR HER2 positive. Okay.
What is that?
So they are receptors on the cancer cell and that determine how you will treat.
Okay.
So now if you are HER2 positive, there's a drug called Perjeta which at the time was costing about 5.5 lakhs per dose.
Okay.
And you would have to take 12 of them. So you're looking at a 65-70 lakh just in the drug outlay cost plus the delivery and coming here because she wanted to do the thing here. So you're looking at a crore-ish in cost. Now, because we had this thing that you see, if you're spending a lot of money, what are you relying on? The question I was asked is that, sir, we have got a histopathology from Nepal. We have never seen such a thing before. Should we rely on this HER2 positive? Now, the other thing that I've embedded in the system is that HER2, which is tested by immunohistochemistry, which is the first way of testing it, okay, is only 70% accurate even if you do it at a very good place.
17 or 70?
70.
70.
So there's a 30% chance it's not what it is.
Okay.
So if you feel 70% that it's a HER2 positive, then you spend 10,000, 15,000 rupees and check it and make sure that it is actually positive 100%.
And how do you do that?
There's a test for
Okay.
it. Okay. So now I said, no, this Nepal thing, I mean, clearly we should, have it rechecked, let's explain to the patient that this is what is at stake. We need to spend 10,000 bucks. If it's positive, it's 10,000 extra that you spend. You spend 1 crore and 10,000 rupees.
Yeah.
Okay.
But it's
So-
negative, you save 1 crore.
Exactly.
Yeah.
And we have to help the patient to get the block. Okay. So we did the paperwork, we helped the patient to get the block and it turned out negative. Okay. Now from my perspective, this was a very bad thing. Okay. Because मेरे को 20 लाख और मिलने वाला था ना. Okay. In a 1 crore spend, I mean, okay, I'm going to earn that 20 lakhs, but I'm going to still get 20 lakhs in earnings.
Yeah.
Okay.
for audience reference, that this 20 lakhs is commission that you would have made, right?
Not even commission. See, every time she's coming, I'm doing some work. I'm getting, I mean, you see, I'm making something on the drug. I'm making something which is a reasonable thing.
Yeah.
So I'm making 10% on the drug, and you see, I'm the balance 10% is my service cost.
Yeah.
Okay, but फिर भी मेरे को 20 लाख का हुआ तो सही ना billing.
Right.
Okay, that's not my net profit.
Yeah.
But I still have 20 lakhs of billing in which I will make some 10, 12 lakhs of rupees. Now my 10 lakhs is gone.
Yeah.
Right? But it's what's the right thing to do. And the other thing is that it didn't need any specialized knowledge, because it was part of the system. That if you're making a decision which has huge impact on outcome or cost, ask what you're relying on.
Right.
Okay.
Right.
So now there are many such things which become protocolized. Right? So I had a patient who came from Darasnam. They had a particular histopathology, but there was something which you see was not consistent with the other reporting. So I said, let's get the block. Now, if we had relied on the original thing, right, the patient needed 8 chemotherapies, full mastectomy, okay, and 40 radiations. Because we felt there was a discrepancy and we retested, which cost us 6,000 Indian rupees to do, it became no chemotherapy, breast conservation surgery, and 10 radiations.
And how much did it save them?
15 lakhs. So not bad. Okay.
So we've clearly established,
okay,
for a doctor to tell you honestly that this is the treatment, this is the process, he might have to let go of 10, 15, 20 lakhs of his own revenue, and if you want him to do that, you have to compensate for his time and efforts.
Yeah, so that's one part, but the other reason I'm telling you this story is that, see, this thing doesn't require specialized skills. You have a system which is telling you, here's a discrepancy. Here is a thing that needs to be escalated. So it becomes scalable. It's not dependent on individual brilliance. See, a doctor is within his rights to say that I have got this thing, and there's no statutory requirement to know this thing has a 70% accuracy, so you have to retest.
So that's what my question is. You have your rules, so those are pretty strong rules. You almost have a constitution for your organization, right? Because you want to make it more than just about one person, which is you. There are no such rules are there no such rules that enforce these practices, and is that the same case in the US? There are no
national rules.
Okay.
There are no national rules.
So, for example, in the US, I only watched a few episodes of House Empty. My wife has, I think, probably watched the whole show, and she keeps showing me bits. I've noticed if they want to prescribe some very strange or unknown procedure or a surgery that costs a lot of money, they have to complete a certain steps. If we have done test A, whether we have done test B, whether we are at this stage, and there's a proper debate among top qualified doctors that make the case for doing such a treatment that costs a lot of money to the patient, without which they cannot proceed. Is that
so? See, it's not statutorily here for everything. There are some things which are there, some things which are not there. Okay, I mean, then India is a big place with lot of issues infrastructure wise, etc. See, I had a patient who was a blood cancer patient, who was my patient. He would come from Ratlam for treatment and then go back same day, and everything was going swimmingly well. Young chap. Okay, now one fine day the wife calls me and says that this guy has a cough, he has fever, right, and it's like 3 days after the chemo. So I said, no, that's problematic. Get a CBC done and send it to me. So they sent a CBC, and his WBC count is under 1,000.
Okay.
So now this is serious, right? So I said that you can't deal with this in Ratlam. Please get here as soon as you can, and I said, okay, we'll have to ICU admit him. I mean, once he came here, I was reasonably sure that I would pull him out. But this would be 3-4 days in ICU, blood transfusions, all this sort of stuff. And I mean, you're looking at a 2-3 lakh rupee hit.
Yeah.
And, everyone is tense, obviously, right, for the patient side, etc. And, when it's complicated, I mean, things can go wrong, right?
Yeah.
So then I said that, you'll come to the center first and I'll just evaluate what is happening and then send you to the appropriate hospital, because maybe it's not that bad and I can put out the thing for 1 lakh of rupees.
Yeah.
So they come here and, these guys have already started him on these expensive IV antibiotics, blood culture done, everything. And I come and I look at the patient and I'm like, this guy doesn't look that sick to me, right? So I said, just escalate his CBC. Okay, CBC comes at 4,500. I said, you have nothing, go back. Okay, because you are a wrong blood work. Now this is not uncommon. Okay. Okay, this is not uncommon. Okay, so essentially, I mean, forget about all these complicated processes, right? I mean, from a Mandsaur or a Khandwa or something like that, which is a large part of India, or even, sometimes Indore, ye wo, right?
Yeah.
I mean, the stuff that you get is rubbish.
Right.
Okay. I had a patient who, was living in a 6-7 crore flat, right? And they would come and cry to me and say that, oh, my husband cannot get up, he has, he gets dizzy, he has headache. Now, I said, see, this is a neurology problem, what will I do? And the neurologist that they were seeing was a very competent fellow. So I said, see, I cannot be better than this guy. Okay. Now, every 10 days they would come and say. So then I said that, okay, let me look at everything again. Now I looked at the MRI and I said that, I mean, I don't see any problem, but, I don't know where this place is, this MRI. Do one thing, let's distrust everything and go to HN, see the neuroradiologist, get this MRI done in this protocol. The moment they did the thing, you saw the problem. That MRI was crap. Okay. In 3 days, the guy was fixed. Now, this is in Bombay. So I had a very rich patient, right? This fellow was being treated for tuberculosis for 6 months. Then he came crying and he said that, I mean, I'm not getting better. So after I took a history, I said that something is wrong. So I got his histopathology done again. Now this guy had non-Hodgkin lymphoma. So he has blood cancer. Now, see, they had sent it to some unknown place which had charged 4,000 rupees.
Yeah.
If you had sent it to a fantastic place, it would have cost 8,000. For that 4,000 rupees, you almost died.
Right.
Okay.
Right.
So when do you allocate resources and when do you not?
Yeah.
Okay.
Yeah.
See, once my cousin, I don't know why they did this stupid thing, but in the school, they had all these 10, 11 years old blood work done.
Yeah.
And then she called me up and she said that, oh, these 3 kids have this, this blood work which is strange.
Yeah.
So I said, 3 kids cannot have this strange blood work. It's the blood work which is wrong. Just recheck it, which was how it was, right?
Yeah.
Now this is in Bombay, right?
Yeah.
In a rich area.
Yeah.
So essentially what you have to do is that in these sort of things, pay that 25% extra, because nobody is giving it to you for 3 rupees and 50 paise.
Right.
As it is very cheap.
True.
But again, see, what we do is we take responsibility for when to allocate resources, when not to allocate resources.
I want to ask you this. You had mentioned your role during COVID, and it's a pretty exciting story, if you can cover that briefly.
So basically, I was involved in a project where an animal model was made. Okay. So what happens is that first you had to understand very quickly why only humans were susceptible to COVID. So the spike protein of COVID binds the ACE2 receptor, right? Now, if you have a good enough binding, it's like a key fitting a lock, then only it will work if you have a certain kind of fit. So every mammal will have an ACE2 receptor.
Yeah.
But the spike protein does not fit in the same way.
Okay.
So it's not that a parrot or a goat does not have an ACE2 receptor, but the spike protein is not binding with the appropriate binding constant, so it doesn't get internalized.
Docking.
Yeah, so it doesn't get internalized.
Okay.
Now, in the human being, the binding is very good. Okay. So it binds and then the thing goes in and now you're screwed, right? Because basically the COVID virus is inside the cell and it will replicate and then, it will proliferate and you see, it will cause havoc, right? If you just get exposed to COVID, but it cannot go into a cell, it cannot replicate, so it will get destroyed. Nothing. Nothing is going to happen to you. So we quickly understood how the COVID virus binds the human ACE2 receptor. What the biological basis of this is, and then with my colleagues we actually engineered animals which were human to the extent that they got COVID. So we actually had human ACE2 receptors in the appropriate distribution in animal models.
Which animals?
Mostly mice.
Mostly mice. Okay.
Okay.
So you inserted those human wala receptors in animal bodies.
No, you have to completely re-engineer the animal. So you are doing an in vitro fertilization on a molecularly manipulated embryo.
You're giving birth to new types of mice that contain
kind of.
Okay. That contain the human-like receptors.
Yeah.
Okay.
Okay.
And you did this when?
Within months of the sequence of COVID being
2020 March, April, something.
Yeah.
Okay.
Okay. Now, so great. So now you have this thing. Now, what's the value of this, right?
How much time did we save to bring out vaccines in the world?
Very hard to say, but certainly some months, right?
Okay.
And I mean, given the level of, infection and the number of people affected, I mean, months translated into millions of lives.
Right. And were you the first of people to make the animal model, which accelerated the whole vaccine production?
Yeah, probably.
You've done something remarkable. You've built something that is going to help humanity in a great way.
Now it's done.
No,
See,
I know.
Now what has happened is now all the vaccines are of no use.
I know.
Yeah.
So I was talking about back then when you have had a breakthrough. Who do you go to with this information?
You see, what happens is you're generally working through large academic institutions which are connected to the government agencies, right? And this is not happening, none of this is happening in India.
Okay.
Right? I mean, this is happening in the developed world,
Yeah.
And it's happening across multiple countries because that time, at least within the academic community, there was a fair amount of collaboration. Did it translate into policies which were useful? I don't think so.
Okay.
Okay.
But it did translate into vaccine production, right?
It did translate into somewhat accelerated vaccine production. It's not that the vaccines would never have come.
Yeah.
And the other thing is that, see, in the interest of fairness, see, like now, these Bharat Serum guys made Covaxin.
Yeah.
They didn't engage with anybody.
Yeah.
Did they have a bad vaccine? Not really.
Yeah.
So little bit is a matka also. Okay.
Yeah.
In the sense that sometimes you may just get it.
Yeah.
Okay. On the other hand, I mean, Sanofi, which is very experienced and a big guy, they made a vaccine which really didn't go anywhere. Okay.
It wasn't effective?
It wasn't very effective, so it never really came into the market, right?
So you were focusing more on the approach of how you build a vaccine that actually works and not just try to build a vaccine in the first step.
See, the more information you have, the odds are better for you.
Yeah,
Okay, but that is not to say that you're entirely dependent on that because I mean, okay, like Covaxin was not a bad vaccine.
Yeah.
Okay, it worked.
Yeah.
Did it have the advantage of this knowledge? Not really.
Some people are saying Covaxin people are better off because Covishield people are getting some side effects.
No, that is a completely nonsense statement, right?
Yeah.
Because see, what happens is people keep on saying that, oh my God, the vaccines have side effects.
Yeah.
Of course, the vaccines have side effects, but the common sense way to think about this is the following. What is the vaccine? It's just the spike protein of the virus being expressed in your body to elicit an antibody response.
Yeah.
Can anybody in the world say that I will never get exposed to COVID in those days? Answer is no.
So you had no other option but to inject.
Yeah, because in what scenario is it going to be better to get exposed to the virus than to just the spike protein? Now, if the spike protein causes some side effects, so be it.
Yeah.
Because those side effects will be much worse when you have the entire virus going mad in you.
Yeah.
Okay.
True.
So I'm not even sure what you're comparing it to. Okay. I mean, of course, everything. But that's how life is. Nothing is perfect.
Yeah.
Everything is a trade-off.
Yeah. So currently, would you advise people who have taken the vaccine? Is there something that people need to change in their routines to maybe take better care of themselves?
Not
Are
really.
there
See,
some known,
not really.
yeah.
See, the thing is that every bad viral infection can have complications and does have complications. Okay, it's just that in COVID it got highlighted because 98% of the world's population got a bad viral infection.
Yeah.
Okay, so when it's 3.5%, okay, that get a bad viral infection, the numbers are just not the same, and therefore it's not really a story in the same way.
Yeah. So now I want to ask you what all things that you've been doing. It's been a while when you came back to India and started doing this. You've treated 70,000 patients. You mentioned that you also do some treatments that are more modern in nature and that are quite convenient in nature. What are those?
Okay, so besides doing the cancer part, right, and even in cancer, see, we also focus a lot on pain management and palliation, which is kind of a very underserved area in cancer. But see, most cancer patients, particularly the ones who are terminal and go on to die, obviously have
Pain
at some point, because you don't just keel over and die, right? So how do you manage this? How do you give them a good quality of life? That is a thing that I've been quite focused and engaged in, and I found that there weren't too many options available to me, where I could refer the patients to. So I figured that we would make it part of our center.
Okay.
So now part of it is, medication, that kind of stuff, right? Using the drugs appropriately. But the other thing is that there is a lot of intractable pain that cancer patients have, which is nerve-related pain, which doesn't respond very well to oral medications, opioids, stuff like that. So now we use interventional radiology to kind of address this. So it's premised on a very interesting notion that actually one way of looking at it is that there's nothing like pain in the world. You cannot buy a kilo of pain. Just as there's nothing like green light in the world, it's a wavelength of light that you are processing as green. You don't know that the parrot or the cow sees the same thing. So actually pain is an electrical impulse which is traversing a particular nerve, going to a specific point in the brain, and it is getting translated as pain. So with the right equipment and the right people, what you can do is you can actually identify where this impulse is traversing from and block it.
Okay.
And if you successfully block this impulse from excruciating pain, you could be in a state of absolutely no pain. Okay. So we have had remarkable outcomes doing this thing.
Can you explain for a layman what is angioplasty?
So about 40-50 years back, if you wanted to do something in the heart, you did the obvious. You cut the heart, you cut the chest open, you went through the heart, and you did whatever you're going to do. Now what you realized about 40 plus years back, okay, is that you could actually puncture a blood vessel, put a catheter, and tunnel the catheter through the blood vessel to the heart.
You would do that in the thigh area.
So initially you did it in the thigh, right?
Yeah.
Now, once the catheter is within the within the blood vessel, you don't know where it is, right? So you need some sort of image guidance to be able to do this. So back in the day, you would take X-rays and see kidhar hai and then push it a little bit further. Now, over a period of time, this thing became sophisticated. So your catheters were better engineered, your imaging was live, and you could just put the catheter and tunnel it through the heart, and you could see everything in real time.
So does it have a camera attached to it?
No, it doesn't. What you are doing is you are using CT or X-rays.
Okay, so you're scanning the body real time.
You're scanning the body in real time, and you are following the trajectory.
Okay,
right?
okay.
And now you can use dyes, etc., to get better contrast, etc., etc. Right? Now, if you can go, so now once you go to the heart, then you can put stents, you can change valves, you can do all kinds of stuff, because now your imaging is very good and your catheters are very well engineered, so you can do a lot more things than you could do once upon a time. But if you can go to the heart using image guidance through blood vessels and through natural cavities in the body, you can go anywhere.
Yeah.
So you can actually do stentings in the brain, you can do procedures in the liver, you can do procedures in the lung, because you have access. So if you have the appropriate equipment, which we have some of the most capable machines in Bombay, and we have some of the best people nationally, you can actually do things other than cardiology too.